Every week now, someone walks into my clinic or into an emergency department on Ozempic, Wegovy, or Mounjaro. And the conversation used to just go in one direction. Weight loss, blood sugar, cardiovascular risk, that was it. But something has shifted because it turns out that these drugs, the ones that have absolutely dominated the headlines for the last 2 years, are doing something far more interesting than anyone predicted. They are changing what happens inside your gut in ways that researchers are only just beginning to understand. We're talking about gut motility, about gut inflammation, about your microbiome, and this is the part that actually stopped me dead in my tracks about early signals around colorectal cancer prevention. This is not just hype. This is peer-reviewed science from the last few years. And if you have a gut, which last time I checked, all of you do, then this matters to you. I'm Dr. Glover, gastroenterologist working in Las Vegas, Nevada. And my goal with this channel is to take research that's sitting in medical journals and translate it into something that you can actually use. Before we go further, if you could do me one quick favor and check that you're subscribed to this channel. It helps this kind of evidence-based content reach more people who need it. And if this video helps even one person understand what's actually happening in their body on these medications, then it's absolutely worth it, right? Let's carry on. Let's start with the basics because there's a lot of confusion about what GLP actually is and where it comes from. GLP-1 stands for glucagon-like peptide, and despite the fact it's now famous because of the drugs like semaglutide, i.e. Ozempic, Wegovy, GLP-1 is not a drug. It's a hormone that your own body has been making in your own gut your entire life. Specifically, it's made by cells called L cells, which are scattered throughout the lining of your small intestine and your colon. When you eat, food travels from your stomach into your intestine. Those L cells then release GLP-1 into your bloodstream. And what does it do? Several things simultaneously. It tells your pancreas to release insulin. It slows down how quickly food moves from your stomach into the intestine, what we call gastric emptying. It travels up to your brain and reduces hunger signals, and it suppresses glucagon, which is the hormone that tells your liver to dump more glucose into your blood. The problem is that your body's natural version of GLP-1 is degraded extremely quickly, within minutes of being released. So the satiety signal you're getting from it is real, but brief. What drugs like semaglutide do is mimic that hormone, but with a much longer half-life. The synthetic version hangs around in your blood for days, not minutes. That's why the effect on appetite suppression and on blood sugar is so powerful. You're getting essentially a sustained, amplified version of a signal your gut was already trying to send. Now, here's where it gets interesting, because GLP-1 receptors aren't just in your pancreas and your brain. They are also found in your gut wall, your immune cells, and your enteric nervous system, which is sometimes called our second brain. That distribution of receptors is driving a whole new wave of research into what these drugs actually are doing in the GI tract. Let's talk about something that millions of people taking these medications have experienced firsthand, and that is the GI side effects. Nausea, constipation, bloating, sometimes vomiting, sometimes gastroparesis-like symptoms. These aren't rare. In major clinical trials, nausea affected somewhere between 15 to 44% of participants, depending on the dose. And why is that? Because slowing gastric emptying is literally a feature of the drug, not a bug. That delayed stomach emptying is part of how it reduces appetite, and food sits in your stomach longer, you feel full, and you eat less. Makes sense. But push that effect too far, and it tips over into something uncomfortable or clinically significant. This became a real conversation in 2023 and 2024 when multiple case reports and then larger studies began documenting that patients on GLP-1 receptor agonists were arriving for surgery with undigested food in their stomachs, even after standard fasting protocols. The American Society of Anesthesiologists and subsequently multiple GI societies had to update their guidelines because of this. If you're going in for endoscopy, for surgery, or any sedated procedure, your anesthetist needs to know that you're on one of these medications. That's not a minor footnote, that's a patient safety issue. And I ask all my patients to hold their GLP-1 medications at least 1 week prior to any endoscopy. But here's the thing I want to be precise about. The effect on motility is not uniformly negative. In patients with diabetic gastroparesis, for example, where the stomach is already emptying too slow, some studies have shown a paradoxical effect in that lower doses of GLP-1 receptor agonists can actually improve gastric function rather than worsen it. The dose matters, the baseline GI function matters. A 2023 study published in JAMA looked at GI adverse events in GLP-1 agonist users across a large real-world dataset, and they found that while upper GI side effects, nausea, vomiting, and gastroparesis, were substantially more common than the comparison groups, the rates of truly serious GI events remain low, meaning the risk is real, but it's manageable and it's context dependent. The practical takeaway: if you're on one of these medications and you have persistent nausea, constipation, or upper GI symptoms beyond the first few weeks of dose titration, that's worth a conversation with your doctor, and it's not something you just push through. Now I want to move on to something that I think is seriously underreported, and that's the emerging data on GLP-1 receptor agonists and inflammatory bowel disease, meaning Crohn's and ulcerative colitis. This is a population that, until very recently, wasn't even included in the major GLP-1 trials. People with active IBD were typically excluded. But IBD rates are rising globally, particularly in countries that have adopted a Western diet. And obesity is increasingly common in IBD patients, so the overlap is very real. GLP-1 receptors are expressed on intestinal epithelial cells, the cells lining your gut. They're also expressed on immune cells within the gut wall, including macrophages and dendritic cells. These are cells that regulate the inflammatory response. And there's a growing body of preclinical and now some early clinical evidence that GLP-1 receptor activation has anti-inflammatory effects within the gut itself. What's particularly striking is that in these tissue samples from patients with active Crohn's disease, GLP-1 receptor expression appears to be higher in inflamed tissues than in healthy tissue. This suggests the gut itself may be trying to recruit this pathway when inflammation takes hold, and the clinical data is starting to back that up. A large observational study using the Danish National Registry data, published in eClinical Medicine in 2021, looked at nearly 4,000 patients with IBD and type 2 diabetes, comparing those on GLP-1 receptor agonists versus other diabetic medications. What they found was a statistically lower incidence of adverse clinical events in the GLP-1 group, including IBD-related hospitalizations and surgery. The adjusted incidence ratio was 0.52, meaning a roughly 48% reduction in composite adverse outcomes. Now, this is observational data. It cannot prove causation. There are confounders, meaning people on GLP-1 medications may have different dietary patterns, different healthcare engagement, but the signal is consistent enough across multiple studies that major IBD research groups are now designing prospective trials specifically to test GLP-1 agonists as an adjunctive therapy in IBD. Those trials are currently being registered. The mechanism proposed involves several pathways. GLP-1 receptor activation appears to reduce the production of pro-inflammatory cytokines, things like TNF-alpha, interleukin-6, IL-1 beta, in the gut immune cells. It may also improve the integrity of the intestinal epithelial barrier, the mucosal lining that, when compromised, contributes to inflammatory cascade in IBD. This is the type of inflammation non-medical professionals hear about, labeled as leaky gut. And there's an additional angle. Because GLP-1 agonists reduce obesity and improve metabolic health, and because visceral fat is itself a major driver of systemic and gut inflammation, the benefit may be partially indirect. I want to be honest with you about where the evidence is right now. We do not have randomized controlled trial data showing that GLP-1 agonists improve clinical outcomes in IBD patients. But we do have mechanistic data, animal data, observational human data, and now some small pilot studies. That's a very credible early signal, but not yet a proven therapy. The next 2 or 3 years are going to be very telling. Now, this is the section I get the most questions about when I mention it in clinical conversations, and it's the one I think has the most potential to change practice over the next decade. Colorectal cancer is the second most common cause of cancer death in the UK and third most common in the United States. It's largely preventable through diet, lifestyle, exercise, screening with colonoscopy. But we don't have many pharmacologic tools that have convincingly reduced incidence for primary prevention. Enter GLP-1. In 2024, a major study was published in JAMA Oncology. It was a retrospective cohort study using electronic health records from over 100 healthcare organizations across the United States. This covered more than 1.2 million patients with type 2 diabetes. The researchers compared GLP-1 receptor agonists against 7 other diabetic medications and found that the GLP-1 group had a statistically significant lower risk of developing colorectal cancer. The reduction was approximately 17%. 17% in a single drug class. That's not nothing. Now, the same caveats apply here. This is an observational studies. GLP-1 users might have different cancer screening rates, different dietary habits, different socioeconomic backgrounds that also affect cancer risk. The study authors acknowledge these limitations. But the biology is not surprising when you think about it. Obesity is one of the most established risk factors for colorectal cancer, particularly through its effects on insulin resistance, elevated IGF-1, chronic inflammation, and changes to the gut microbiome. If GLP-1 agonists are reducing obesity, improving insulin sensitivity, and reducing gut inflammation, you would expect some downstream cancer risk reduction. The signal makes biologic sense. There's also an additional mechanism worth knowing about. GLP-1 receptors are expressed on colorectal cancer cells themselves, and in cell culture studies, GLP-1 receptor activation has been shown to inhibit colorectal cancer proliferation and promote apoptosis, meaning programmed cell death. Whether that anti-tumor effect translates meaningfully in human tissue is still being investigated, but the receptor is there, the biology is there. What this does not mean is that GLP-1 medications should be prescribed for cancer prevention. That is not where we're at yet. That's not where the evidence is at currently. Yet, what it means for millions of these people already on these medications for metabolic reasons, there may be an additional GI benefit we are only just beginning to start to quantify. And it raises a real pressing question about what role these drugs might play in colorectal cancer prevention in high-risk populations, particularly those with obesity, metabolic syndrome, and a family history of colon cancer. I want to close the main content with something that I think is going to be a major story over the next 5 years, and that is what GLP-1 medications are doing to the gut microbiome. The microbiome is a community of trillions of bacteria, fungi, and other organisms that lives in each and every one of our intestinal tracts. It shapes our metabolism, our immune function, our inflammatory state, and how gut hormones like GLP-1 are secreted in the first place. We are just beginning to understand the importance of the microbiome and how it relates to human health. Multiple studies have now shown that GLP-1 medications consistently shift the microbiome in the same direction. Specifically, increases in bacteria like Akkermansia, Mucinophilia, and Faecalibacterium prausnitzii, 2 species associated with reduced gut inflammation and better metabolic function. What's fascinating here is that this creates a potential feedback loop. GLP-1 agonists reduce obesity and inflammation. That changes the microbiome. A healthier microbiome then produces more short-chain fatty acids from dietary fiber. And short-chain fatty acids, butyrate in particular, directly stimulate L cells in the gut wall to produce more GLP-1 naturally. So the drug may be partially restoring a gut biology that has been dysregulated by the very disease it's treating. This is still early science, but it starts to reframe what these medications are. They're not just appetite suppressants, they may be gut ecosystem modulators. And understanding that will matter enormously for how we use them, how we optimize them, and what we expect from them over the long term. So let me bring this back to something pragmatic for your benefit. The GI side effects are real, predictable, but manageable. Slow dose titration is the single most important thing that you can do to minimize side effects. Starting at the lowest dose and going up gradually gives your gut time to adapt. If you're having persistent nausea beyond the first 4 to 6 weeks at a stable dose, that's worth investigating further, and it may be something beyond simply the expected adjustment period. Tell every clinician that you see that you're on one of these medications. That means your GP, your gastroenterologist, your anesthetist, especially before any procedure requiring sedation or general anesthesia. The delayed gastric emptying is clinically significant in that context. The IBD and cancer signals are extremely encouraging, but not yet practice changing. If you have IBD and you're also a candidate for a GLP-1 agonist for metabolic reasons, that's a conversation worth having with your gastroenterologist. But these drugs are not yet indicated specifically for IBD or cancer prevention, although the studies are extremely exciting. Diet and the microbiome, however, still matter. The bacteria GLP-1 agonists seem to increase. Akkermansia and Faecalibacterium are the same bacteria boosted by a fiber-rich diet, fermented foods, and minimizing ultra-processed foods. The drug and high-fiber diet may be working in the same direction. Stacking them is probably better than relying on either alone. So, GLP-1 medications. They started as a diabetes drug. Then they became a weight loss phenomenon. And now we're looking at data suggesting that they may reduce gut inflammation, lower IBD flare rates, cut colorectal cancer risk, and remodel the microbiome in ways that feed back into better metabolic health. We are still in the early chapters of understanding what these drugs do, and the gut, not the brain, not the heart, not even the pancreas, might turn out to be where the most interesting story is. I know this was a big video, and thank you so much for watching. If this resonated with you, leave a comment below. I'd really love to know, had you heard about the potential GLP benefits to the gut before, or was this all new to you? That tells me a lot about what to cover next. And if you want more content like this, where we take real science and translate it into something you can actually use, then subscribe to the channel. Just the evidence, explained clearly for your benefit. I'll see you in the next one.